Hi, Krupali. Thank you so much for doing this with me and agreeing to participate in this little project. Um, I was wondering if we could start with you telling us just a little bit about yourself. Who are you as a professional? What do you do? This whole jazz.
All right. Yeah, absolutely. So I am a clinical mental health person. I currently live in Klamath Falls, Oregon, which is Southern Oregon, and I am working at the only community mental health program, or CMHP, in the area. And we're considered rural. So we serve the counties around us, and basically there's no other large-scale agency or CMHP for like 60 miles on either end of us, or all the way around us. I am a supervisor of adult outpatient services, slowly moving into temporarily supervising case managers clinically until this pandemic stuff is done and hire people. So taking on some extra responsibility there. And then I also hold a small caseload myself.
Cool, thank you. Mm-hmm. That's a lot. And yeah, that's a full load.
Yeah.
Or, and very different roles kind of that you're moving throughout your days. It also sounds like. And so the reason for this interview is to help master level clinicians who are either still in training or just entering the field and understand the role of assessment and what they may expect to be using assessment for once they join the workforce. So from the position of the supervisor, mental health clinician who practices in a rural area, how do you understand the role of assessment in the counseling field?
So as a community mental health person, assessment to me essentially equates, like, and I'm going to be as graceful as I can with my answer here, reimbursement. So like in the community mental health setting, assessment is important. It's necessary if you're expecting to get reimbursed by, if you expect your agency to be reimbursed by the insurance, because the assessment produces the diagnosis, and that's that. So but from a personal level, I think assessment is a really great tool that's not necessarily a default, but I think it is very helpful. It could be used in diagnosing, but I also think that it could help clinicians get deeper into issues that clients may talk about that we may not understand because of cultural components or familial components or whatever it may be. I think it also adds this like idea of like quantitative data, informal, I guess, quantitative data to lend more evidence to what we may have been talking with clients about. So like the scores you would see on like a PCL-5, which is for trauma, like, oh yeah, we did talk about that, and now we have the numbers for it, where there's proof that, not proof, but there's evidence to it.
Some evidence, yeah. Kind of going off of that, what kind of tools or assessment tools do you use in your daily practice?
Daily practice, so with the agency, they've picked up, so we do the biopsychosocial assessment. I think is pretty standard. Like, asks questions about presenting problem and reason for visit and, trauma history, developmental history, things like that. And then we also do, so we have the full assessment, which usually takes like an hour and a half to 2 hours. And then every 90 days, we have a smaller version of that assessment. So some of the parts are taken out, but essentially we're asking the same thing for treatment updates and things like that. And then along with that, so our agency uses this Pathways to Care model. So it's a trauma-informed model, and basically clients are put into pathway 1, 2, 3, or 4, depending on their needs. So like people who may come in with basic needs who are in crisis all the time tend to get connected to like case management, peer support groups, things like that, with their needs. Whereas
just wrap around.
Right, exactly. And then like the higher pathways are more for counseling and doing like the trauma work or whatever it may be. So for that, we need to complete the DLA 20 to figure out the functioning level, which...
What does it stand for?
The daily living activities. And there's like 20 categories. Yep. And then we use the ACE score to also determine, so those two scores together determine which pathway the client goes into. And then we also use, sorry, did you say something?
No, sorry.
Oh, it's okay.
I didn't.
Okay. And then we also use the PHQ-9 because...
it's the internet connection.
I know. We also use the PHQ-9 because the county has been seeing lots of suicidal, or a rise in suicides over the past few years. And so we're collecting data on that through the PHQ-9. And then we also do like, for substance use, we use like the CAGE aid, and forget what it's called, but I think it's the CAGE aid for gambling or something like that, for addictions.
Mm-hmm.
And then those are just, okay, so those are the ones that are on the assessments.
Mm-hmm. Yeah, that's quite a bit. It almost feels like you're showing up to your to your community health center, and you get kind of a battery of tests administered right off the bat, to kind of orient the clinicians and the team as to like what this participant or client needs. I'm curious, considering this like rural context in which you're working, and I can imagine there's not too many places. You said that you guys are the only place for mental health, really. So there's not too many places for like evaluation or referrals. I'm curious about how do you conceptualize boundaries for using assessment? So like at what point would you say like, I can't do this, or maybe there's a different response to encountering boundary, you know?
Yeah, so when you say boundaries, I think of like multiple relationships. Is that what you're referring to, or are you just saying boundaries in general?
I guess in boundaries for using assessment, you know, like in my master's program, we were presented with, for example, Rorschach, which obviously now I know we cannot use unless, you know, you have extended training. And I think it is one of the assessment that is kind of monopolized by psychologists. So there are, I guess, the professional boundaries with sister professions that let us do certain things, but not the others. And working in this like kind of a microcosm of a rural community, how do you deal with that?
Gotcha.
Or Krupali, if you have a different interpretation of boundary within assessment, application or practice, please like elaborate.
Okay. Yeah. No, I think I was thinking multiple relationships because I just got done reading articles for a class. So, so no, I think the boundaries as far as assessments go, we as an agency, between myself and the program manager, we provide trainings to our staff. And when we say our staff, I mean like the first Wednesday of every month is our all staff meeting. So half of the day is set up for trainings, and then the other half is set up for like information that the CEO
Mm-hmm.
shares with us. But so the half-day trainings that we have are based on like things that the agency is going through. And so a lot of the time we're introducing not necessarily assessments. I mean, it's like different modalities, different tools you could use. So sometimes there's assessments involved. And so like so we are very clear as far as what the boundaries are. So the entire adult outpatient team does come to the training. So that includes case managers, skills trainers, peer supports, SUDS counselors, things like that. But we make it clear as to who is able to use these assessments and why and how it could benefit your practice. The assessments that I talked about earlier, though, the ones that are just automatically part of our process, only our QMHPs go through that training at the beginning during their NEO, which is the new employee orientation that the agency provides. So I think just based off of that, the QMHAs don't even get that information.
Who's QMHA?
Oh, sorry. So QMHPs are like therapists, so qualified mental health professionals.
So like licensed professionals.
Yes, or state like interns that are
candidates for licensure.
Yeah, and then QMHAs are qualified mental health associates, and so those are like non-licensed, like case managers, skills trainers.
Got it.
Things like that. So, yeah, so our QMHAs don't even get that training. It's like the information is only like geared towards the QMHPs when they come in.
Got it.
I've had situations where case managers have come to me, even before I came into this temporary role as like clinical supervisor for them. They would come to me and ask me for ways to help a client or consult on a case. And they would, through their own Google searches, they would find these like tests or assessments to use. And, we'd have to do our research. Like if I didn't know anything about it, I would probably say, no, let's like wait until we figure out who can use this type of thing. So now they know, the team right now at least knows that whatever assessments or tests they find, they need to do extra research. They can't just
go in and administer. Are there any specific like multicultural or diversity considerations when you're doing assessment with your populations or when you're supervising people doing assessment?
That is something that I always keep in mind because I feel like I'm just oriented that way. And this is a difficult answer for me to, difficult question for me to answer, because the people that I counsel and the people that I supervise are usually like they're typically, actually I think I'm like one of two brown people in my agency. So they're all white, European descent individuals. And so of course there's like the factor of male female,
sure.
Like that. So I do take that into consideration, as well as socioeconomic status in our town is pretty important to consider. So when I'm thinking about supervisees, I feel like I don't have that much further to stretch as far as the cultural components go. But when it comes to clients, it's not necessarily like race or ethnicity or anything like that, or like religion. It's more or less, components of socioeconomic status, gender, things like that to consider. So, yeah.
If you could change something about the use of assessment with your population, or if you have like a broader idea in the macro of the counseling field, what do you have any ideas or thoughts?
I think in the broader sense, like overall, I am a huge advocate for multicultural factors, like to do something better with them. And I don't have the answer to it, but I think like not to pigeonhole assessments towards like, oh, well, when this was tested with African American people, you know, versus Caucasian people, this was the different, because, you know, every individual looks different, which I know we can't account for every single individual, but
sure.
I feel like something different needs to happen there. It's kind of like where the counseling training is going, you know, headed towards where it's like, it used to be like, you work with Asian Americans this way, you work with African Americans this way. But now they're saying you can't generalize like that. Like you just have to ask questions to get to know them. And so in a general perspective, I would say that's where I would like to see some changes being made. In my practice though, like in rural work, I think, and I think this is just coming from the fact that I just read, I'm teaching the ethics class at the local university, and I'm like going over multiple relationships and things like that. And one of the things that I am really concerned about is that the culture of rural America is so different from urban America that and everything is built around urban America, including the assessments, you know, like there are some questions in the DSM inventories that I'm just like, well, this doesn't even make sense. Like this would not tell me anything about this specific population, because that's not even relevant to them, you know? So I would like to see more focus on like assessments that speak to rural populations.
Okay, so Krupali, you were talking a little bit about the diversity and also ethical considerations that as an ethics teacher you are probably more sensitized to. And I'm curious about this. What are the ethical considerations that you see in administering assessment in your work?
Yeah, so...
Or supervising it, whatever, you know.
Oh, yeah. So I think with assessments, the community that, or the clients that I work with there are certain things that need to change, I feel like, with the assessments, because the assessments that we use, even included in the biopsychosocial, has to be tweaked just a little or changed just a little, whether it's me changing the wording or helping interpret how to interpret the question to be able to answer it. And so what I've seen as a big ethical problem is just I think the wording of the assessment. And I think that with most of the clients that I've worked with, I think the language needs to change up a little bit just so they understand what they're giving consent to. So, and whether that has to do with education level or socioeconomic status or culture, and a lot of clients here are Spanish speaking, you know, and there are things in the assessment that I'll have an interpreter in the office with me, but they won't know how to interpret certain words, or they don't know how to interpret certain concepts that happen, because the clients will say, I don't know what you mean. And then they have to come back and say, well, they don't know what you mean. So then I have to try to figure out how to tie it back to something they understand. So I think, the biggest ethical thing is like the wording of the assessment.
It's a very pragmatic answer that I have not encountered yet. So I appreciate that, because that feels like an application. You know what I'm saying? Like what is the most common barrier that as people who are developing those tools sometimes don't even think about.
Right.
What could that be? So
Yeah, and
Yeah,
I
that's
think
great.
it goes back to the fact that these assessments are made in, oh, well, I shouldn't say all, but like most of the time it's like these big universities, big city researchers making them for big city agencies,
Mhm.
and it doesn't translate well with
Sure.
population.
Okay, thank you for that. And to wrap up our little talk, my last question is kind of a bit of wisdom that you would like to pass on to the master level clinicians. So, what would you like master level clinicians to keep in mind as they are entering this field about assessment?
That's a really good question. So I actually just encountered in our last ethics class, one of my students, I was talking about informed consent and all that fun stuff. And one of them raised their question and says, so do I have to give them a diagnosis by the end of all of by the end of that hour that I'm sitting with them? And I said, if your agency wants to get reimbursed, yes, and if you want the informed consent to be signed truthfully, then yes. So one of the things, the thing I would say for master's level students is just that there are going to be things that are overwhelming as far as the assessment process goes, especially if you're going to end up in community mental health, because there's going to be a lot of pressure to get things done right now, right here. And my, I guess, words of wisdom, I don't even know if I would call it that, would be just to kind of slow down, take a deep breath and look at the big picture before you take a step forward, because if you don't, there's going to be a lot of ethical issues that you have to deal with, and you don't want to get into that. Like as far as like the informed consent that's attached to the assessment, like you don't want to mess up on something just important like that because you were just trying to get a signature or something like that. So yeah, take a step back and look at the big picture.
Awesome. Thank you. That is truly a advice of a practitioner.
Yeah.
Don't freak out, okay? Like everything's gonna be fine. Just take a deep breath.
Yeah.
Yeah.
It's
Awesome.
and it's inevitable. Like I can't. There's no way that any of us can stop the chaos from happening. So yeah.
Yeah. Thank you so much for your time and for your energy put into that. I really appreciate it.
Yeah, absolutely. Thank you. This was fun.
Yeah.